First off, thank you, Bob and Marianne, for all you do. My name is Rob Ramirez. I'm a medical oncologist at Vanderbilt, specializing in treatment of patients with neuroendocrine tumors and thoracic malignancies. So I saw there was a handful of patients with neuroendocrine tumors of the lung here. So this is for you, and hopefully the rest of you can learn something from this as well. The neuroendocrine tumors. We call them uncommon. We call them rare. They can start anywhere through the body, and the majority of them start somewhere below the diaphragm, but up to a quarter of the time they start out in the lungs. So that's what we'll talk about today. So when we talk about the neuroendocrine tumors of the lung, they represent a broad spectrum of disease. We call them the pulmonary carcinoids on one side of that spectrum, and then on the other side we call them the neuroendocrine carcinomas. There's the risk factors kind of vary with this. With the high grade neuroendocrine tumors, we think smoking is a risk factor. The lower grade tumors, we say, well, maybe there's a genetic syndrome associated with some of them, but really there's in many cases there's really no risk factors. As I mentioned, about 25% of neuroendocrine tumors start out in the lung, but despite when we think about lung cancers in general, the low-grade tumors represent 2% of all lung cancers. So when you were speaking with my thoracic colleagues around the country and around the world, this is not top of their mind because it's not something they see all the time. The non-small cell, small cell is much more common than this. We've seen this graph before, so this looks at the incidence of neuroendocrine tumors in general, and we said previously that the incidence is increasing compared to all other cancers, but this is just neuroendocrine tumors of all different types. This line up here, that's lung. So that incidence seems to be increasing even more so. And, again, I think it comes down to more awareness. And then let's face it, anytime you go to the ER with a stubbed toe, somehow you end up with a CT of the chest. So we're picking up more and more of these things. So symptoms can vary, but when these things do produce symptoms, they're primarily respiratory symptoms. So I see a lot of patients with recurrent pneumonias, and you can see this is a pretty ugly chest X-ray, big tumor there. So cough with or without blood, difficulty breathing, wheezing, chest pain. Every now and again, this can produce a hormonal syndrome as well. Not commonly, but we see it from time to time. And then a lot of these patients present incidentally. So and it's up to us to try to figure out, how long has this been there? So digging back through records and really trying to figure out what's next. And I'll talk more about that. So the imaging for this is, similar to imaging with the neuroendocrine tumor, the GEP-NETs. So we like to get a contrasted CT of the chest. Usually this all starts out with a chest X-ray and then leads to a contrasted CT of the chest and abdomen. We also, MRI if there's liver involvement, that is the best test for the liver. Has anyone had an Octria scan? So a few of you. So don't ever get those anymore. That's the old technology. Every now and again I see someone come in and that's all they have, and we always end up sending them for PET. So in either gallium-68 or copper-64, they're very similar. Gives us similar type pictures. So either one is fine. So when we look at these types of malignancies, they range in degrees of aggressiveness from very slow growing to very, very aggressive. They're graded a little bit differently than the GEP-NETs. So this may be a little hard to see, but we go from typical carcinoid to atypical carcinoid to large cell neuroendocrine carcinoma and small cell lung cancer. The last two related to smoking. And we come up with that classification based off of the mitotic index. So how are those cells dividing? So think back to your high school, college biology courses when you learned about chromosomes and cell division. It comes back to haunt you now. And then the presence or absence of necrosis or cell death. But importantly, on this classification anyway, Ki67 is absent. But on the newer classification, it breaks it down into a little differently now. So we still see the typical and atypical. We still see the large cell and small cell. But now we've got this category in between. So these are carcinoid/NETs with elevated mitotic index and or Ki67. So akin to those well-diff grade 3s. So there was always that gap between the atypical carcinoids and the large cell neuroendocrine carcinoma. So now we've got this other category. All right. So we've talked about this and how important this is. So it is really, really important to be discussed in a multidisciplinary setting. So these two patients, same diagnosis. These were both atypical carcinoid tumors of the lung, but the treatment options vary quite a bit between these two. So when we think about, how is this multidisciplinary discussion held, and it varies by institution. At Vanderbilt, we have tumor boards for everything. So everything's very disease specific. So myself, I present my patients in two different conferences. My thoracic conference and my neuroendocrine conference. So, and I think each one brings something to the table. So this is sort of how it used to be. Pre-COVID, we would all sit in a room together, and we'd put up images. It's kind of hard to tell, but there's images at the end there, and the person who is presenting the case would discuss this is Mrs. Jones. She's 47. She has a history of a pulmonary carcinoid tumor. She was diagnosed on this day, and this is where we're at with treatment. We wanted to review scans and talk about candidacy for surgery. So then the radiologist will normally go through all the scans and say, all right, well, this is what we're seeing here. And then the surgeon will weigh in and say, yeah, I think that may be resectable. Go back, let me look at that scan again. And what are the breathing tests like? And then their pulmonary doc will say, all right, these were the breathing tests. And the pathologist will weigh in as well. And then we all, at the end of that, we all come together and say, all right, candidate for surgery, or let's do this first, or so that's the tumor board. That is, it's real-time planning with everybody involved, and it's really important to have those discussions. It also offers a very good opportunity for teaching of our residents and fellows. So you see, usually the residents and fellows are on the side. But we'll often pick on them and say, all right, how would you manage this patient, and put them on the spot, and that keeps them engaged as well. But yeah. So and sometimes we have to bring patients back for further discussion. So yeah, always ask about when you're in your doctor's office. Ask about that. Or, am I going to be presented at the tumor board, or can I get another set of eyes on this? So. All right, so some of the factors we think about when considering treatment for lung neuroendocrine tumors. So we look at stage, we look at symptoms. Does the tumor have somatostatin receptors? That's very important. The tumor burden, the comorbidities, if you can, lung function. So unlike, we talked about cytoreductive surgery, we really can't do that in the lung. We can cut out so much before you run into a lot of trouble, and obviously patient preference. So the treatment for early stage neuroendocrine tumors of the lung is surgery. We take it out. So. And it really depends on the extent of surgery depends on a lot of different factors. We try to minimize, how much lung we take out. Traditionally, we'll take out a single lobe if we can get away with it. Sometimes less. Sometimes we do something called an anatomic segmentectomy. There is, in those patients who are not candidates for surgery for whatever reason, sometimes patients, they say, I don't want an operation, but they have a tumor that's there. There's a type of targeted radiation that we can do, something called stereotactic body radiotherapy, or SBRT. And then I put down here, adjuvant treatment is not indicated. Okay, so adjuvant treatment is chemotherapy after surgery to try to kill off any micrometastatic disease to minimize the risk of recurrence. And we do adjuvant treatment in many, many different types of cancers. So non-small cell lung cancer and breast cancer and colon cancer, and we've got very good data to support that. With this, we don't have that data. So this is a paper we wrote a few years ago that looked at the role of adjuvant therapy. And we actually looked at all the guidelines as well, and all the papers surrounding this. So these are the major organizations that take care of these patients. So you can see NANETS, ENETS, so NCCN. That's sort of the gold standard in the United States and around the world. And then ESMO, which is the Europeans. And so this is kind of hard to see, but all the way up to stage 3s, we're looking at for typical anyway. So all of this is surgery without adjuvant treatment. Okay. When we look at stage 3 atypical carcinoid, the only organization at the time was recommending surgery without adjuvant treatment. So NANETS was the only one. The rest said, yes, you should do adjuvant treatment. So we looked at all that data and said, all right, well, how did you come up with this recommendation? Because you think that it may be beneficial. We're supposed to be evidence-based. That's what, prove to me that this is beneficial. And so we went back and we looked at all of that. And it turns out there's evidence to suggest adjuvant treatment in lung is actually detrimental. So most recently, we updated the NCCN guidelines, and so now on NCCN, this is not recommended. So with these, there's a special type of problem we can sometimes run into with the pulmonary carcinoid tumors. These things can clog up the airway, and what you see here is a cross-section, left lung and right lung, and here's the airway, and there's a tumor blocking that. And this particular patient, he's in his early 30s. He came in with cough and wheezing, and was found to have that. And they biopsied it, and it was a typical pulmonary carcinoid tumor. And so, but there's no other disease elsewhere. Okay, so we think with this, if we were to take this person to the operating room, we'd be looking at probably losing that entire lung. Okay, so, and that's a tough sell for a 30-year-old. So is there something more that we can do? It turns out there is. So we can do something called endobronchial therapy. So this is a sort of an umbrella term for different ways to try to get rid of that particular tumor that's only on the inside of the airway. So we can freeze it, we can cook it, we can laser it. There's different ways to do this, but it does provide definitive treatment for this and near immediate improvement in symptoms. If we need to, we can go back and do an operation later, but then we always surveil these patients. So what you see here is this endobronchial tumor sitting right there, and then they ended up doing cryotherapy with this. 6 weeks later, they went back, and you see that airway is now completely opened up. You still see maybe a little bit of residual right there, but then going back at 8 months, all of that is gone, and your scan goes from this to this. So that's something that we work with our interventional pulmonary team, and so we do lots of this. So what about, not everybody's a candidate for that or candidate for surgery, and someone who has metastatic disease, for instance, what are our options? So we've got several. The first one I put on there was observation, and we'll talk more about that. But we use the somatostatin analogs. If they have liver disease, we learned about liver-directed therapy today. So there's sometimes some chemotherapy, the radionuclide therapy. Maybe there's a role for immunotherapy. We've got the targeted therapies, and then I'll talk a little bit about clinical trials. So who am I observing? Okay, so. All right, so this is a patient you can see with, so this is a cross-section through the chest. So left lung, right lung, here's the airway. And so what you're seeing here is all these nodules. Those are all tumors, okay? So this is not somebody that I'm going to operate on. The whole point is to stop all of this from growing, okay? But if I have a biopsy that says this is typical carcinoid, and this was found incidentally, and the patient is asymptomatic, I may say, well, these things may have been there the last 5-6 years and not, we're just, or longer, and we're just now finding out about this. So before I rush into treatment, I want to know, all right, what are these things going to do? They may just sit there and not do anything. So those are the patients that I say, all right, well, let's get a scan on you in another 3 months or 6 months. And then, if you start developing symptoms along the way, or if we see a scan that these things start growing or new things start popping up, then start treatment. And there's plenty of patients of mine that I do this with that have been out 3-4 years and nothing is happening. These things aren't doing anything. So not a big rush to go and start something. But when we do want to start something, we've got usually, if in a patient like that, I would tend to start on a somatostatin analog. So we've got 2 of them. That we use octreotide LAR or lanreotide. And these were approved based on these two studies we talked about. But we've got to keep in mind that ProMid was done in midgut neuroendocrine tumors, and Clarinet was in GEP-NETs, so not in lung. Okay, so we do have some data for lung based off of the SPINET trial, which was supposed to be a large trial of over 200 patients with neuroendocrine tumors of the lung that were randomized to either get lanreotide or placebo. And we were trying to figure out, really ask the question, what is the role here? So this was presented at NANETS in 2021. And what the issue with this trial was, because of the rarity of this disease, this was a worldwide trial, but it was halted early because there just weren't enough patients. So they ended up, at the end of the day, with 77 patients out of the north of 200 that they wanted. The majority of these patients were typical carcinoid patients, and it turns out that there did seem to be a benefit in use of lanreotide. It seemed to be more pronounced in the typical carcinoid population. Unfortunately, this trial has never been published, so it hasn't gone through peer review. But this is the best data we have so far. So we use it, and as part of the guidelines is an option for that first line. But what happens when things start growing afterwards? Or the other thing we always think about is if I've got a patient that does not have receptors, how effective is lanreotide? Well, theoretically, it really shouldn't be. So maybe they never even saw lanreotide. So we've got to think about other options here. So we talked a little bit about the mTOR inhibitors. So everolimus is what is called an mTOR inhibitor. So this drug inhibits this certain pathway that these cancers use to grow. This is based off of, there's several trials looking at this. So it's approved in pancreatic neuroendocrine tumors initially, and then this trial pushed this forward into the GI carcinoid tumors as well as lung. And so this was everolimus versus placebo, and so this is everolimus, this is placebo, meaning that the everolimus did better. So 11 months progression-free survival, which means that half the people needed something additional at 11 months. So what about PRRT? So we've heard about the NETTER-1 trial. So this was lutetium dotatate versus high-dose octreotide LAR. So 2 shots each month. So these were patients with, again, these were midgut neuroendocrine tumors, grade 1 or 2. And so what they found was a very significant improvement in progression-free survival. Overall survival did not meet statistical significance because the majority of these patients went on to get Lutathera. But again, this is in midgut neuroendocrine tumors. There is data for lung tumors, but it is primarily retrospective data, and we always like to scrutinize retrospective data, but it's the data that we have. So we use it, and we used to get pushback from insurers to get this, especially right at the beginning when this came out. We knew that at least we felt that it would be beneficial for lung patients. But the insurers said, nope, it's not on that label, so we can't use it. But then the major organizations started coming forward with their guidelines saying, yes, any somatostatin somatostatin receptor positive tumor, this could be beneficial. So now we don't have much trouble getting this for our lung patients. So there is a trial. We talked earlier about sequencing. So there is a trial looking at this in a prospective fashion to answer the question, really, which one should we be doing? Should we be doing lutetium first or everolimus first? Everolimus is the only FDA-approved treatment for this. So this trial will randomize patients to either lutetium dotatate versus everolimus, and then if patients end up on the everolimus arm, they can cross over if there is progression. So this trial is sort of just starting out. We have it open. It's open at multiple centers. So this is something we always consider. What about immunotherapy? So there's immunotherapy has changed the way that we have that we take care of cancer patients. So I'm sure you've seen commercials on TV for Opdivo or Keytruda. These are immunotherapies. And they work really, really well. In my non-small cell lung cancer patients, we use this all the time, and we're trying to figure out, all right, should we use it after? Should we use it in early stage or metastatic? It's very proven in metastatic, and now we're moving it into early stage, and we're looking at treatment with immunotherapy even before surgery, and so there's a lot of push for this. But in the neuroendocrine world, the immunotherapy has been pretty disappointing. So there's many different trials that have been done with immunotherapy, and it just really hasn't panned out to be something really beneficial. So when we look at a trial called Keynote 028, so this was in patients with carcinoid or pancreatic neuroendocrine tumors. The overall response rate, which means shrinkage, was only 12%. And the PFS, or progression-free survival, was less than 6 months. So, but it seems like the lung we may have better outcomes in lung. There's another one called spartalizumab that showed that overall response rates were only 7% in the cohort of neuroendocrine tumors, but in the lung, it was almost 17%. So maybe there's something different about lung. Combination immunotherapy, so a drug called ipilimumab and nivolumab. This trial looked at a large cohort of patients, but in the neuroendocrine patients, there were 29 patients. Their overall response rate was 24%, but for lung it was 33. So, and then the clinical benefit rate. So that means not necessarily response. That means, did I stop your disease from growing? It's actually 72%. So we use this. It's sort of later down the line when we use it, but I've certainly seen very, very dramatic responses and able to keep people stable for a long time. So you've heard about this combination chemotherapy, capecitabine and temozolomide, or CAPTEM. Very effective in patients with pancreatic neuroendocrine tumors, but there is data in lung as well. And so this was a retrospective study, a small study, 20 patients, but sometimes that's all we have to work with this disease. And it turns out that this is an option here. So a disease control rate of 85%. And most people do pretty good with it. They touted a median progression-free survival of 13 months. So that's, again, retrospective data, but that's better than the FDA-approved therapy of everolimus, which was at 11 months. So I think there's something to it. This is another something else that we use. But I will say more research is definitely needed with this disease. This is, we presented this at NANETS last year, where we looked, we just kind of came up with this idea and asked the question, how many lung abstracts are being presented, lung carcinoid abstracts are being presented at the national meetings? So we said, all right, the big neuroendocrine meeting is NANETS. And then the big lung cancer meeting, which is actually going on today, that I chose to be here instead of Singapore, is called the World Conference on Lung Cancer. And so this happens on different continents every year. It's an amazing conference. But what we did was we said, all right, well, this is the numbers are kind of hard to see, but all right, so here's the NANETS meeting. NANETS, we get about 120 abstracts presented every meeting. Okay, versus the World Lung, this is about 17,000 abstracts over several years. We went back to 2013, I believe. But what we can see is the total number of abstracts versus what was included in lung. And then you can see down at the World Lung, there's hardly anything. And then, primary pulmonary carcinoid tumor clinical trials. So at NANETS, 2 of them. And at World Lung, out of these 17,000 abstracts, 3. So it's pretty abysmal, but hopefully we can change this. So I'll just talk a little bit about, we talked a lot about research and clinical trials, and should I, has anyone ever taken part in a clinical trial? So a few people, so thank you. So this is really important. This is how we learn how to treat patients or how not to treat patients. So just briefly, when we think about clinical trials, there's different types of clinical trials. So we hear about preclinical trials. So this is done in the lab. All right, so they're synthesizing a new agent that we think may be beneficial. So we do it in the lab, and we do it in mice, and before this ever touches a human. But then we talk about phase 1 trials. So essentially, a phase 1 trial is mainly for, we have a drug, and we want to know if it's safe, and we want to find out the right dosing for it. So sometimes we say, all right, we have drug X, and it looks good in the lab, and now we're going to put it in humans, and maybe, say it's an mTOR inhibitor, for instance. All right, well, it's an mTOR inhibitor, so it should work in neuroendocrine tumors, and, we'll try to get a hint of if it does, but it's really about safety. So they start at 1 milligram in a few patients, and if those patients tolerate it, then they go to 2 milligrams, and if those patients tolerate, they go up, and then when they stop tolerating, then they go back down, and they say, all right, well, this is what we're going to do for our next phase of the trial, which is a phase 2 trial. So these are smaller studies, so usually about 40 patients or so, and really meant to determine, does this treatment work? So many times these are single arm studies where that's everybody gets the actual drug, and so we get a hint of whether or not it works before we go to a phase 3 study, and that is a larger study. So usually these are 100 or more patients in these studies, and there's plenty of times where phase 2 data looks great, and then we move it to phase 3, and we find out it doesn't work. So those are sort of the trials that you may be asked to participate in. It gives you an option to get novel treatments. You have a large team reviewing your care, so it's not just your doctor. So all these trials are very standardized and with very strict inclusion and exclusion criteria, and you have that whole other team looking after you. So I would definitely encourage that if it's if there's a trial that. Oops, I skipped over that. So if there's a trial that you're approached about. So some of the endpoints of the trial, the best for the number one endpoint we look for is survival. Dave, can we make this? Does this drug improve survival? But with neuroendocrine patients, it's sort of not. It's not a realistic. In many cases, a realistic endpoint, because patients do live a long time. So, and they've got lots of other lots of other treatment options available. So the big thing that we look for is the progression-free survival. So when a patient gets on the drug to when it stops working, when disease starts growing again. So you'll see a lot of our trials. And then response rates, again, does your tumor shrink? And there's very strict definitions for this as well. So it may shrink 20%. That's still not considered a response. So it's actually, when we talk about responses, that means shrinkage of 30% or more. So shrinkage is shrinkage to me. All right. So speaking of trials, so we talked a little bit about targeted alpha therapy. So again, this is a similar rationale to the lutetium dotatate. So which is lutetium dotatate is what's called a beta emitter. So that the alpha emitters use higher linear energy transfer with a shorter path length. So theoretically, this should produce more damage to the DNA where it's not able to be repaired. So there's a lot of different clinical trials that are looking at this, not just in neuroendocrine either. This particular trial, you saw a little bit about this. So this was a preliminary data on lead-212. This was presented or published last year by Dr. Delpasson. So 10 patients were reported. This is a pre-treatment scan, post-treatment, and this is in a lung net patient. So 80% response rate. So it's, this is just phenomenal. We never see 80% in anything. So stay tuned. That's looking promising. The actinium trial. We heard a little bit about that. That is not including lung patients, but again, this may be something that we can extrapolate in the future. Could we have a new option? We heard a little bit about cabozantinib earlier. So this is a type of drug that inhibits the growth of blood vessels. So this was tested and presented in 2017, actually, at the ASCO meeting, which is our big oncology meeting, where they looked at patients with well-differentiated grade 1 or 2 neuroendocrine tumors of the pancreas or carcinoid tumors, including carcinoid tumors of the lung. And they got put on cabozantinib once a day. It's an oral agent. So there were 41 carcinoid patients in this, with lungs being 12%. Okay, so not a huge population, but what they found was really stability of disease with this. Again, this isn't one of these drugs that's going to make things shrink and go away, but if we can stop it from growing, that's the biggest thing. As I had mentioned earlier, we've seen lots of compounds in phase 2 trials that look promising. We take them to phase 3 and they don't work. But we just got this. This was a press release, and the drug companies do this for some reason, where they actually said they announced positive results from the phase 3 trial in advanced pancreatic and extrapancreatic. So they actually stopped the trial because they found that this drug was beneficial. Now we don't know any of the data. We don't know how beneficial this was, but this looks like it's going to be a new option. So I won't walk you through all of this. This is our general algorithm for treatment of patients with neuroendocrine tumors of the lung. It really starts with that multidisciplinary team. Are we a candidate for surgery or endobronchial therapy versus medical therapy? So it really starts with all of that. So and I'll just conclude by again reiterating that the neuroendocrine tumors really do require this multidisciplinary approach. We talked about surgery being that mainstay for early stage lung neuroendocrine tumors. Endobronchial therapy, again, maybe if we can spare you from having a big surgery, that's what we want to do. There's newer options coming, so but certainly we need more research. So please feel free to send me an email with questions. I'm always happy to discuss some other options and let you know what's going on at our center. But thank you so much.